Well, hi, everybody. Neal Shore here with two wonderful colleagues who are remarkable leaders in the field of GU oncology. As I said, I'm Neal Shore. I'm the director of GU oncology for Star Cancer Research, and I'm based in Myrtle Beach, South Carolina. We have Tanya Dorff, who is a professor of medicine and an esteemed colleague in medical oncology and therapeutics. She's the section chief at City of Hope. Additionally, Alicia Morgans, she's associate professor, Harvard Medical School, director of the survivorship program at the Dana-Farber. We've got four great presentations we're going to go over today from ESMO, just happened a few weeks ago in Berlin. A lot of great content. We're going to review the ENZARAD trial. That'll be Dr. Morgans. I'll review EMBARK. Dr. Dorff will review the Capitello trial. I'll follow up with the PSMA edition. We're going to do fairly brief, quick presentations with an opportunity for the three of us to give our takeaways, and then you all will have some opportunity for some Q&A at the end. So with that, Dr. Morgans, the ENZARAD trial.
Hi, everybody, and thank you for inviting me to participate today. I'm so excited to talk about the ENZARAD trial. This was a highly sought after trial that was really run through the cooperative group, the Australia-New Zealand cooperative group, and presented by Dr. Nguyen at ESMO. This was a randomized phase 3 trial of ADT with radiation therapy with or without enzalutamide for patients with high-risk or clinically localized prostate cancer. And it was meant, I think, in many ways to understand whether enzalutamide might be used in a similar way to abiraterone, which was demonstrated in the STAMPEDE trial, in combination with radiation to improve metastasis-free and overall survival. So I don't think we have the schema here to show, but if we do, we can talk through that. Essentially, it enrolled patients with high risk disease. Some of them could have been node positive. Patients could have had a PSMA PET scan, but this was not required by the study. They certainly had high Gleason scores consistent with high risk disease. And they were enrolled and randomized to treatment with radiation with 2 years of ADT plus 24 months of enzalutamide versus 2 years of ADT plus a conventional non-hormonal or general antiandrogen like a bicalutamide, nilutamide, or flutamide type medication. Primary endpoint here was metastasis-free survival of the overall population, and overall survival was a secondary endpoint. Patients were stratified by whether they had a clinically positive N1 disease by conventional imaging, whether they had Gleason score 8 to 10, clinical T3 or 4, their PSA level, and age. And when it comes to that primary endpoint of metastasis-free survival, there was no benefit in metastasis-free survival to adding enzalutamide to 2 years of ADT plus radiation versus ADT and radiation in that standard way. So it did not seem to benefit the overall population in terms of metastasis-free survival. I think really importantly, though, the investigators, to their credit, continue to investigate and understand whether certain subpopulations or groups may have benefit, even though the overall population did not see a benefit to the addition of enzalutamide in this setting. They found that patients did seem to have a prolonged metastasis-free survival if enzalutamide was added to ADT in 2 years of ADT plus radiation, if patients had N1 disease, as well as if they had pelvic field radiation. Now, this was a complicated thing because this was not dictated by the trial, but was at the investigator's discretion, which may included people who had PSMA PET positive nodes or other reasons to have pelvic field radiation, but that was an independent predictor. And then there was no benefit in that very high risk disease as defined by NCCN. And then otherwise, I think they discussed in this why these patients may not have benefited. Is it because enzalutamide is not as effective as abiraterone, which most of us think is probably not the whole story and probably not the story at all. Many of us use enzalutamide and abiraterone in various settings sort of interchangeably. And so then the question is, are there differences in the populations that were enrolled? And when it comes to that, there were clear differences between the ENZARAD population and the STAMPEDE population of locally advanced and very high-risk localized disease that was enrolled actually many years ago at this point in time. A greater population or portion of the population in STAMPEDE had clinical N1 disease. This seems to be a population that benefits more from that addition of the ARPI. And a greater population in STAMPEDE seemed to have clinical T3 and T4 disease, 92% in STAMPEDE versus 47% in ENZARAD. So these features, these high-risk features, which may correlate with benefit, were enriched in STAMPEDE and may be a reason that we did not see this in ENZARAD. I think ultimately, as I consider the implications for this, I believe that I will be a little bit more selective, perhaps, with where I do that intensification, adding on that ARPI in combination with ADT times 24 months with my radiation for this population. But I think it absolutely raises more questions, and I do look forward to seeing additional analyses coming from this study to help understand better what was happening.
Yes, great. Tanya, your thoughts on a negative trial, essentially, with a population that was successful, as Alicia points out, but essentially a negative trial. So what are your thoughts?
Yeah, I don't think it's that enzalutamide didn't work. I think we all know it's an active drug. I think the radiation is very good, and we cure a lot of patients with radiation with our standard added hormone therapy. So I absolutely think some of it was patient population. They die of competing mortality causes. And so we always have to look at the patient in front of us in their complete context when we're thinking about whether or not to intensify. And I do hope we'll learn more when the NRGG-009 trial reports out, where they use Decipher scores to select patients for intensification. And maybe we can get to a more personalized approach.
So quickly, so we can get to the other presentations. Nick James, I thought, did a really nice job as the discussant. And when asked, as he described it, yes, it was this trial was not positive, but yes, it was particularly robust for the patients who had node positive disease, higher PSAs, a more advanced local disease. And he said, would you use enzalutamide in the STAMPEDE successful trial that led to abiraterone being included in the NCCN guidelines? And his response from the stage was an unequivocal yes. So to your point, it's not that there's a biology difference in the AR blocker. It's just that the way that the populations were selected. There are two other really important trials for our audience to keep their eyes on, and that's the DAZEL high cap, similar to the localized high-risk ADT 2 years of darolutamide, and the ATLAS trial, another similar population with 2 years of ADT and apalutamide. So with that, let's move over to the EMBARK trial. This was a pleasure for me to see this come to a plenary presentation, 11 years in the making. And Steve Friedland, my co-PI in the study, presented the overall survival with enzalutamide in biochemically recurrent prostate cancer. I think a lot of the audience should be familiar with the 3-arm trial design. As you said, started 11 years ago. These were BCR patients who had failed either radiation or prostatectomy and adjuvant radiation. Population was enriched for a PSA doubling time of less than or equal to 9 months. The arms of the combination ENZA LHRH Q3 month versus LHRH and placebo were blinded. There was an open label enzalutamide monotherapy arm based on the 160 milligram approved dose and many other indications, in both for really, at the time, it was for resistant disease. Now we have it in MCSPC as well. There was an opportunity for an interruption at 37 weeks or a cessation of drug if patients' PSAs were under 0.2. The primary endpoint was metastasis-free survival, which had already been presented and published and presented about 2 years earlier, receiving regulatory approval, EMA, FDA, and some other agencies. This was the final overall survival analysis, which was clearly positive. The previous MFS for combination was 0.42 in the combination arm, 0.63 in the monotherapy arm. The final hazard ratio now that was presented was for the combination arm was a hazard ratio of for OS of 0.597, which we feel is probably one of the lowest hazard ratios in phase 3 survival trial in prostate cancer. So we were very pleased to see that. It has a p-value of 0.0006. Interestingly, the monotherapy arm did not reach statistical significance with a hazard ratio of 0.83. It's trending that way. The risk of death being 17% lower, albeit not statistically significant, which leads to the discussion. And I'm interested to hear both what Tanya and Alicia feel. How does this change anything in terms of offering a high-risk BCR patient combination versus monotherapy? There were no new additional safety or side effect issues. So we were just very pleased to be able to present this, and it was simultaneously published at the same time in New England. So let me stop with that and ask you, Tanya, what were your thoughts on this final OS data?
Well, it's very exciting to see OS when we're studying an intervention in such an early stage of the disease. And I think it fits with what we've seen in the movement of intensified therapy to metastatic hormone sensitive. So it makes biologic sense, but still really exciting. And I think really cements the importance of offering this in patients with high risk BCR.
Yeah, no, thank you for that. And Alicia, your thoughts?
I could not agree more. I know, Neal, we've talked a lot about surrogate endpoints and the need for these when we have so many subsequent therapies. Well, apparently this AR pathway inhibitor is extremely strong, and we don't need a surrogate endpoint when it comes to this strength of a treatment. We got a sense of this, I think, in the non-metastatic CRPC setting where we saw that these drugs could prolong survival, but I did not necessarily expect that we would see it in a hormone-sensitive, high-risk BCR setting. So kudos to everyone. And I would also say kudos for in continuing to follow these patients, because this is one of the longest follow-ups that we have. There are many studies that find an advantage to a certain treatment and don't necessarily continue to follow those patients over years or even a decade. The follow-up information here is a long-term follow-up, and it really completes the picture and is very, very helpful and very encouraging for patients who experience this, that they do have a long road ahead.
Yeah. Well, thanks very much. Great comments and insights. I think it's really important for the field. It gives patients choices. Let's go to the third trial, a completely different biomarker selection, a different MOA, and look forward to hearing more about this. Tanya, if you wouldn't mind presenting the Capitello 281.
Yeah, so as we've been talking about, the importance of personalized therapy, we're finally seeing this in action. So we know that a significant proportion of patients with prostate cancer have an alteration or a deletion, a deficiency in PTEN, and that these patients have this excessive signaling through the PI3 kinase AKT pathway that can drive prostate cancer growth and make the cancer overall less responsive to traditional AR-targeted therapy. So this was very rationally designed. We had the iPotential trial previously with ipatasertib in CRPC that was negative, but they learned from that trial and designed this specifically in patients who harbor PTEN deficiency. So the molecular selection was critical for this trial. They did have to screen over 6,000 patients to enroll just over 1,000. And patients were randomized to ADT and abiraterone with placebo or ADT, abiraterone, and capivasertib with a primary endpoint of rPFS. And so, of course, this made a big splash because it was positive, with more than 7.5 months gain in median rPFS from 25.7 months to 33.2 months with the addition of the capivasertib. Now, of course, that does come with some extra toxicity. So there is diarrhea, there's hyperglycemia, and there's rash. This is sort of what we see with this class of drugs. So always have to have a risk-benefit discussion. We don't yet have overall survival because it's too early, not enough events. But one thing that was really compelling was even though all patients were selected for PTEN deficiency, they showed that the greater the PTEN deficiency, sort of the more that the cancer might be addicted to that PI3 kinase AKT pathway signaling, the greater the benefit. So a really nice, compelling story for molecular selection.
Yeah, absolutely. But it's really interesting. A lot of things come to mind in this trial. Some practical issues just regarding combining oral therapies when they combine with abiraterone, which is sort of two medications if you consider the prednisone, and this was a 4-day on, 3-day off, a BID formulation, 200 milligram BID. But then also, to me, the really important issue, Alicia, I'd love for you to comment on, is this whole notion of testing. They did IHC as opposed to NGS and eye potential, as Tanya was saying. This strictly focused on immunohistochemistry. Your thoughts on Capitello?
Yeah, so I guess when it comes to the IHC, my understanding from talking to folks involved is that this was a more reliable way for them to find the population, because finding the absence of PTEN or this PTEN deficiency was not necessarily as accurate as they wished for it to be. And eye potential had its challenges, I think, with biomarker identification. I do think that the cutoff for when we say this patient is going to most benefit from this targeted treatment for PTEN deficiency is a bit of a moving target. Now, in this trial, about 1/6, or I guess it was 25%, I should say, of patients were identified who could enroll, who had a 90% PTEN deficiency on IHC. But with each iteration of kind of getting closer and closer to 100% deficiency, there was this improvement in ultimate response to the therapy. And if we decide that we're going to use this in practice, where we may draw the line, whether that's at 90% deficiency or 95% deficiency or something even more, I think will be important, because for an individual patient, taking perhaps a little bit more complicated regimen and going through this testing is going to need to be paid off with hopefully a big bang for their buck. But I think ultimately, I'm just so excited that we are breaking down metastatic hormone-sensitive prostate cancer into a disease that has drivers, and we are targeting those drivers. So this is a positive study. It's absolutely informing our field, and I really look forward to seeing where this lands.
Yeah, I completely agree. I love the point that you made, Tanya, that like they learned from the eye potential study, which I think maybe all three of us enrolled patients in that. And kudos to Chris Sweeney and Johan de Bono for leading that study. But yeah, they learned, and they took this kind of cut point of 90% deficiency and greater, and really showed that those are the patients who had the best response. And as you say, I've seen some of that data too. When you go from 90 to 95 to 100%, the curves separate even that much more powerfully. And I think we all agree that personalized based biomarkers is really helpful. I think it was 40% of patients in the resistant disease had PTEN deficiency, about 25%. What I've also come to learn is that there may be some differing racial prevalence. It seems to be a little bit higher in PTEN loss in Asian and Caucasian populations, less so in African American or other Black populations potentially, which is rather a fascinating finding. My question is, this, IHC, the whole notion of making sure that there's really good, high quality IHC, across the community and medical oncology and uro-oncology clinics, as opposed to just the more sophisticated academic medical centers, and what will be the concordance of that across the board. But then additionally, just getting testing in general, NGS with or without the IHC. I think I've kind of moved towards asking for IHC regularly. I actually get it now also for HER2 as well, given the tumor agnostic indication for DDXT. But any thoughts about the testing conundrum that we sort of live in outside of the three of us? We test everybody, but we're still in early days, is kind of my assumption. Tanya, your thoughts on the testing challenge?
Yeah, it's a good point, but I think we're seeing throughout the field of genitourinary oncology the need to add in IHC and not only use our DNA sort of NGS, right? So we're in bladder, we're starting to look at HER2 and MTAP deletions. I think we're going to rely on our partners in industry to create companion diagnostic that's really going to help us select the right patients. As we get more and more treatment options, and we'll be talking about PSMA addition in a moment, it's so important to pick the most appropriate therapy for the patient. And that really will require access to a reliable and broadly available biomarker test.
Yeah. Alicia?
I would agree. I would say in prostate cancer, probably in most practices, we're not reflexing to IHC yet. So without that support, without that companion diagnostic, it's not going to happen. So we really need to sort of lay out these new SOPs. We need to integrate them into our workflows, and we're happy to do it. But we need the support to get there.
Yeah, I think it would probably be really good for, the sponsor to consider some unbranded disease state deck education prior to them for, hopefully getting approval. I think this will just kind of lift the field regarding testing in general. And I think we're all acolytes of precision-based therapy. All right, so that's awesome. So now we had look, the NZRAD was had a subpopulation that was positive but otherwise negative trial, and wonderfully presented by Paul Nguyen. And then we have the Embark, a positive trial. We have the Capitello, a positive trial, and now we'll present the PSMA addition, yet another positive trial. And indeed, one can argue biomarker selected if we think about imaging as a marker, and I think it is. So this was the phase 3 lutetium-617 combined with combination ADT physician choice of ARPI versus the doublet. And so the schema was pretty straightforward. It was a 1-to-1, as I just described. The primary endpoint was radiographic progression-free survival. Patients were really low and high volume. And for the most part, minimally treated, most part de novo. They could have had some early ADT utilization. Crossover was allowed. It ended up being a fairly small amount, and the OS, it's a little bit too early to go through the OS, but the bottom line is that this was a successful trial. It has not yet reached the median on the RPFS, but the hazard ratio was 0.72, favoring the addition of 6 cycles of lutetium, the traditional dose that we see in both VISION and in 4. For the audience, VISION was in the post-chemotherapy MCRPC population. PSMA-4 was in the pre-chemotherapy MCRPC population. And so the curves start to separate at about a year's time. There was it's too early. It's a fairly immature looking at the survival events, and so there's really none yet to see anything in terms of any decrement, which is always reassuring. I think overall, there's really no new safety or tolerability issues that we hadn't already been aware from both the phase 3 VISION and 4 trials, which was additionally reassuring. And there was no clinically significant difference ultimately in quality of life and pain scores. But, I think that one of the questions that gets asked quite a bit, and I'll kind of push this back to the two of you, is, okay, we, at least in the US, non-US, I'm not really aware of much regulatory approval yet, although in a lot of places outside the US, there are, quote, what are described as radioligand therapy homebrews. We see this in parts of Europe and parts of Australia. But lutetium-617 is right now, for the most part, pre and post chemotherapy resistant disease approved in the U.S. So I guess a question that I'm leading to is, do you start this early for patients who are PSMA PET positive, which was a criteria for the trial, which was like in 4 and VISION, it's all around somewhere hovering in the high 80s, like 90%. There may be about 10% of patients who don't have adequate PSMA positivity. So the real question is, do you give it in sensitive disease, or do you wait for patients to progress to resistant disease? Your thoughts, Tanya?
Well, these are very exciting data to be sure, but I'm not quite ready to jump in and start using it in practice. You know, of course, we would like to see a little bit more maturity on the data. These patients with metastatic hormone-sensitive prostate cancer can live 5 to 10 years, and late toxicity becomes a concern. I agree with you. We saw no concerning safety signals, which is so reassuring. But I don't think the follow-up is maybe quite long enough to completely address some of those concerns. And many of us feel that the 6 doses every 6 weeks in this setting may not be the optimal way to utilize this agent as well, because when we're just starting our hormone therapy and our ARPI, we know that target is disappearing pretty rapidly. And so I think there's more work to be done on how to best apply this agent in metastatic hormone-sensitive prostate cancer, including patient selection as well as dosing schedule.
Yeah, so here's a triplet. You know, and yet we have now a whole, quote, embarrassment of riches of potential triplets. We have the doublet with docetaxel, a la piece 1, and Arasens. We have now Amplitude demonstrating a triplet with niraparib, an ADT, and an ARPI for BRCA selected patients primarily. Now we have this triplet population. We have other PARP triplets coming out. There may be additional unique MOAs coming into the notion of kind of first shot, best shot, if you believe in that strategy for patients who present de novo MHSPC. Alicia, how as Tanya points out, it's not approved, but if it were, how should we start to think about this regarding this this potpourri of options that we may have? And let's maybe assume that someone's not a BRCA positive.
Yeah, I think we should definitely assume they're not BRCA positive, because I don't think those patients were included in this trial. And I think we would want to use a PARP in that setting, or most of us would. I think that this gives us another option, but it's all about patient selection. I completely agree with Dr. Dorff, because we increasingly, I think, can do testing to understand who might have the best outcome from a given regimen. And that's ultimately what we wish for our patients. We don't yet have data on SUV mean. Is this a way for us to determine who might most benefit from this? We don't necessarily know if maybe we're going to start using Decipher to understand which patients really would benefit most from chemotherapy in their triplet. And then, of course, there's patient factors like fitness for chemotherapy or not. Some patients are going to have SPOT mutations, or others who might have extreme responses just to ADT and ARPI. There are so many things that we still have to learn. This is another option, and it's always good to have options for our patients, and amazing to have another registration trial that is positive at a major meeting. So really, as you said, an embarrassment of riches. And I agree with both of you in terms of the fact that we still have much to learn.
Well, other than, I thought ESMO was fabulous this year. I mean, I think Berlin is a magnificent city, and that from a geo-oncology perspective, it was pretty awesome. I think the conference logistics were a little bit of a challenge, kind of navigating the pathway a bit there. But let's see, do we have any questions here from our audience? Here's one that I've heard a lot, and I want to put this back to you. We love precision-based care, so and we still are really kind of far behind the 8 ball, so to speak, in terms of next generation sequencing on somatic liquid-based testing, germline testing, and now we bring in this whole importance of potentially getting IHC, which I've been doing and asking my commercial vendors to get it regularly. How are you approaching this, Alicia, and then Tanya, and then I think we'll close.
You mean in terms of IHC? I'm actually, if that's for the question, yeah, I'm not using IHC in prostate cancer yet. We don't have IHC availability, and we're not using HER2 targeted. I have not seen anyone that I would use a HER2 targeted treatment in yet. But clearly, I'm behind the 8 ball, so need to get up with everyone else.
There you go. And Tanya, what about just for the field in general and the notion of testing?
It's important for us to be doing this in all of our patients with advanced disease and doing it earlier than maybe we used to, because these treatments are moving up from CRPC into earlier disease settings.
Yeah, I think that's really the most important take-home message that I would say would 100% endorse. So for our audience, you can get CME credits for this. There is a link at the bottom. You see the QR code. I want to thank, Professors Morgan and Dorff so much for their leadership in the field. And we really appreciate you listening. You can go on to the ESMO website and get these slides. And kudos to all the presenters and all the study sites that brought these to ESMO this year and the forthcoming publications. Thanks very much, Alicia and Tanya.
Thank you so much.
Thanks, Neal.